Odds are, if it hasn't affected you, it's affected somebody you know. We have a surgical breast oncologist in the house today to discuss breast cancer in women and what can be done to bring those numbers down. The Health Source podcast starts right now.
You are listening to the Health Source podcast, presented by the Marshall Health Network. Now here's your host, Rick Lord.
Hello again, and welcome inside the Health Source studios on the campus of Marshall University for this Health Source podcast presented by the Marshall Health Network. I am your host, Rick Lord, and today we're going to be talking about some startling numbers. Breast cancer, 1 in 8 women will have to deal with it at some point in their life. About 1 in 50 women will die from it. It is the most common form of cancer in women and the second most deadliest. But there are some good evolving trends to talk about and some numbers that hopefully will give you some help and hope for the future if it is something that is in your life right now. And to talk about all of that and much more is Dr. Mary Legenza, a surgical breast oncologist with the Marshall Health Network. Thank you so much for your time today, Doctor. It's a pleasure to have you, and we look forward to a nice talk today.
Thank you, Rick. I appreciate that.
Let's begin with just a little bit about your journey and your path. What led you into this field, and what brought you to the Tri-State and the Marshall Health Network?
Well, I'm actually from the area. I am local. I'm from Ironton, Ohio.
There you go. Go Tigers.
Well, I was a flyer.
Oh, were you?
Little tiny St. Joe.
Yeah, sure.
So, but I knew early on I wanted something with science, medicine, and I actually went to medical school thinking I was going to be a family doctor.
Okay.
I fell in love with surgery and became a surgeon and came back to the area, practiced surgery, and I did general surgery for quite some time, but fairly quickly into practicing general surgery, one of the fields that I saw the biggest changes was in taking care of somebody with breast cancer. And you mentioned that, it's high volume, but really, even in the late 80s, people didn't have a lot of choices for what kind of treatment and not as much hope. And I saw that change very radically in the 90s. Yeah. And less surgery sometimes gave you the same results, and a lot of changes with medication that meant people survived. So, but what also was very, very important and what led me to be a breast surgeon was that you had to stay on top of it. You could not just say, oh, well, I learned this, 5 years ago, because things were changing constantly. So I was in a large group, and I said, let me tackle this, let me do most of the breast surgery and stay on top of this, and it's been very rewarding.
We mentioned hope and help and numbers. There are some promising numbers out there in terms of all stages of breast cancer. Right now, there's about a 90% 5-year plus survival rate, and early detection brings that up to about 99%. So we are doing better in terms of finding this early and treating it. And that might be, and excuse me if I'm wrong here, that might be one of the reasons why rates are actually increasing a little bit, because we're finding it earlier and then people are doing a better job of getting in for those screenings. Is that something you'd agree with?
That's absolutely right. Mammograms have gotten better.
Right.
They're still the standard, and that's fantastic, but you're right. We are finding more and more stage 0, but that's the easiest to treat, less chance that it's going to go anywhere or give anybody a problem. So we would always prefer it to be stage 0 or 1.
And that's why it's so important to get those routine screenings. Just talk a little bit about why breast cancer is such a significant concern and why it's so important to stay on top of that.
Well, you talked about the volumes, and that's really the biggest thing. But although it's very, very common, we also know that it is very, very treatable and curable, and you're right on with those numbers. The earlier stage is more important. Also, though, what we have found really over the last 20 years is the biology of the tumor. The behavior of the tumor is more important than when we find it.
Wow.
The size, the lymph nodes, those are important, but what we do now is we get a little more information, and people talk about genomics, and you hear a lot about it, and you're like, what is that? But there are specific things of the tumor that we need to test for that tell us, how is this tumor going to respond? Sometimes, I'm a surgeon, so most of the time they come to me first, but sometimes they might need chemotherapy or targeted therapy, or maybe even immune therapy with one of those before they have surgery.
And I would assume that there's a couple things at play here. Number one, the tumor, the size of the tumor, and what type of tumor it is, and the things that you just discussed. But also, early detection can also make sure that it hasn't spread, which obviously is a big concern as well. A lot of people might have some misconceptions, like, okay, well, if it's just a tumor, go in and cut it out. But if it's already spread, that you're bringing in a whole new ballgame here.
Well, and that's a lot of my conversations every day with my patients. They've heard the word cancer, and they walk in the door and say, okay, remove my breasts. I want to move on with my life. And then we have to sit down and have the conversation that, I'm sorry, but it's not that simple. If that was the case, we would do that for everybody and everybody would be cured. But that's not how you cure cancer most of the time of the breast. Most of the time we have to worry that it could be throughout the body, even if it's a small tumor. It really is related to those receptors, the estrogen, the progesterone, and this HER2. But here's the other good news. So triple negative, if all those are negative, it's a lot more aggressive, even at a small size. But treatments have changed, and we have much better medication. When I first started into practice, somebody would start on chemotherapy and invariably end up in the hospital.
Sure.
They were sick. Now, people hardly miss work.
Wow.
Depending on your situation, you still lose your hair, but you can work through it most of the time and
We all do
really
eventually.
well.
Well,
I don't know.
My hairline.
I don't know.
I'm not
My
trying to be
mom's
flippant.
91.
Right.
She still has her hair.
I'm not trying to be flippant about a very
I
serious
know.
subject.
It is very serious.
But at the end of the day, something like losing your hair is just cosmetic, and that's something we can all deal with. And then, I would hope that people out there understand that that's.
It is. And I've never put. Yeah.
That's not going to be the end all be all. You want to make sure you're taking care of what's making you sick first of all, and the rest can take care of itself. You talked a lot about the evolving technologies and the advancements and things that have you excited. What are some of those maybe surgical mastectomy techniques that have evolved, and what makes you excited for the future?
So probably the biggest thing that has happened through my career is that we really focus on de-escalation. So when I first came when I was in training, the standard was mastectomy, nothing else. Even for a small tumor, you always had to lose the whole breast. Then, gradually, we had the wonderful research studies that showed you could actually just take the lump out. But we were still taking all the lymph nodes from under the arm, which means women ended up with very large swollen arms many times. So in the early 90s, late 90s, we started doing something called sentinel node biopsy, where we only took out a couple nodes. So we've gone from, big surgeries to smaller surgeries with the same outcome, which is wonderful. Now we're looking at, well, wait a minute. If somebody's 75, small tumor, nothing in the nodes, maybe they don't even need their nodal surgery, or maybe they could skip radiation, which is still a standard if you have a lumpectomy. Right. So the de-escalation is let's look at what we're doing already and maybe cutting back some of those things.
That's interesting.
Instead of doing more.
The age thing, is that kind of like a numbers game where you say, okay, well, this is a technique that it might not cure you permanently, but if it's an outcome that gives you 30 to 35 more years and you're already 70.
It'll cure you.
Okay, perfect.
Oh, it's for cure.
Okay.
Oh, we're not doing less. You'll still be cured.
Right.
The idea of radiation is it's going to prevent recurrence.
Right.
So, and you're right. If you're 80, you probably, most of us don't have 20 more years after that.
Right. They would sign up for something that could get them to 110, right?
I don't know. All of us want to live well.
Right. Exactly. Quality matters.
Yeah. So really, it's just, it is a numbers game. Like, what can I do to give me a great outcome, not interfere with my day-to-day life, but still give me a good chance of never having to deal with this cancer again.
Right.
Yeah.
And I would imagine that you probably run into some people that even when you're dealing with something like cancer, which, the C word, that they still might be a little leery of surgery or skeptical of it. What are some of the most common myths and misconceptions about surgery that you have to deal with on a daily basis with some of these patients?
I think the biggest thing is just that some people think, oh, I have to lose my breast. Right. And then they find out there's other options and they're very relieved because the people in their family, that's what they did. Right. That's all grandma had to do. Yeah. So that's probably the biggest one. And the other one is what we already talked about too, which is surgery, although it can be curative at stage 0, we usually have to use other modalities if it's beyond that, if it's even stage 1.
And as with any field in the medical profession, as technology advances, you're learning more and more about the role that genetics play in all of this. How do screening guidelines and genetic testing alter and affect your surgical plans?
Well, a lot. And I'm going to back up on the genetics because it's so important. But a lot of people don't really know their family history.
Right.
So, and I would say, please talk to your older relatives as soon as possible before they're gone, because there's a lot of misconception of, well, yeah, grandma died really young, but I don't really know what she had.
Right.
Was it ovarian cancer? Was it breast cancer? Which are things that may be a BRCA mutation, and now we can test other members of the family.
Yeah, that's coded into your DNA.
Yeah. So you have a 50-50 chance if one of your parents carries that gene, and we can actually be proactive and prevent you from ever having cancer by doing surgery ahead of time, which is fantastic.
So how would that work? How that's amazing to me. So do you can target like areas that you think would be most.
Well, no, it's the whole breast. So let's say somebody.
So it would be a mastectomy.
Yeah. So let's say we've got a 40-year-old woman with a family history. We do testing, and she does have, let's say, a BRCA, because I know those numbers off the top of my head.
And at that point, you're like, it's not a matter of if, it's when.
It's 80%.
Right.
So it's not 100. You don't have to do it.
Very,
we can
very
follow
likely.
you closely. We can do not just mammograms. We can do
Interesting.
MRIs. But if we do a double mastectomy, and we can do that with reconstruction, we take that risk from 80 down to 5%.
Wow.
So it's not 0, but
Right.
it's a huge difference. The other thing is she's also at risk for ovarian cancer, which is much, much harder to screen for.
Mm-hmm.
So we usually recommend at least sometime in the 40s have tubes and ovaries removed to also prevent that.
That's amazing. And a lot of people think, okay, well, the mastectomy, the routine screenings, the self tests, that's how you find it. If you find a lump in your breast, you have. Are there any other symptoms or any other things you need to look out for before it gets to that point?
So so you're right in that. Well, so mammograms are still our best.
Sure.
And really, and if you think about, a mammogram can find a cancer small blueberry size.
Okay.
If you're waiting until you feel a lump, it's going to be an uncracked big walnut.
Okay.
So think of the difference
A lot
of those
bigger.
two things.
Sure.
Yeah. So that means it's a later stage, and doesn't mean it's more aggressive, but we found it later in time. So that
you've lost
means
that time.
you might now have it spread throughout the body. It might at least be in the lymph nodes. So that changes the treatment. So that's still the gold standard, but mammograms miss about 10% of breast cancers. That means it picks up 90, but you have to be aware of your own body, and that's what you were asking. The question was, what do you look for? So obviously a lump, and I have so many people that say, well, how do I find a lump? My breasts are lumpy, and I say, yeah, they're not a bag of Jell-O. They've got fibrous tissue, fatty tissue. They can be hard to examine.
Yeah.
So whoever examines your breast, your OBGYN, your family doctor, breast surgeon if you're high risk, have your exam, go home and do your exam, and go, okay, this is a normal exam for me. And then look for changes. You're looking for something hard like a marble, not just soft lumps usually. But if you feel something, even though your mammogram was normal, you should call it to the attention of your doctor and not ignore it, and
Just to check to
get
see
it
what it
checked. Probably needs an ultrasound.
And I would imagine that there are maybe some false positives as well. So I would imagine that a mammogram isn't the end-all, be-all. There's probably a series of things to do. So walk us through the process of diagnosis, if you will.
A lot of false positives. So if you have a routine mammogram, and it's very scary, you get a mammogram, somebody calls you and says, come back and do additional views. 80% of the time, it's nothing to worry about.
Yeah.
But you have to find out. You have to go back and do additional views, maybe an ultrasound, which we do for the majority of time when it's, one of the things we look for on mammogram are little white dots called calcifications. That can be a sign of stage 0 breast cancer. But the other things we look for is obviously lumps or what we call asymmetry. So one side looks different than the other. So an ultrasound is probably needed. The next step after that is if there's something there and the radiologist says, yeah, this is suspicious enough, then you go and have a biopsy. So it's either ultrasound guided or mammogram guided, and either a breast surgeon or a radiologist does that. And then usually somewhere between 2 and 5 days later, you'll get a call that says, this is what it is. Obviously, if it's not cancer and everything looks good, you usually follow up in 6 months with some kind of imaging.
Okay.
If it's cancer, then you're usually referred to a surgeon first, and you sit down and go over your options. And again, that's where those receptors are so important, because if it's very favorable, if it's estrogen receptor positive, and this HER2, which tells us that it's an aggressive tumor, if that's negative, then sometimes, let's go ahead and do surgery. And the other thing is, if you're young, you mentioned genetics earlier, I want to know your genetics before we go forward, because what if you carry a gene mutation that not only increased your risk of getting this cancer, but in 15 years you have an increased risk in the other breast. So we might be more aggressive surgically, not to treat the current cancer, but maybe to prevent a second one.
Sure, and such a nuanced and complex journey that brings in an emotional, physiological, physical toll. As a surgeon and as a part of the Marshall Health Network, one thing we found is that you guys have a good team, right? And there's a lot of teamwork involved in all of this.
Yes.
So what's it like when you get to that stage where you're like, okay, you have cancer, here's what we're going to do, and you as a surgeon obviously take care of one part of it, but do you bring in other people as a support team as well to help them on that journey?
Absolutely. So we start with, we've got our nurse educator, and she spends time with the patient. We have our whole genetics team that comes in usually very quickly in the journey. And then we have our medical and radiation oncologist, not just the oncologist, but you're right, it's a whole team. Oh. When you, there's social services and there's pharmacy, and just, we get a lot of people together and we talk about the whole thing. I mean, when I first meet somebody, we're talking about some of the options, but I'm also talking to them about, how's your transportation? Can your family get you here? And we always encourage people to bring their families with them.
That's such a huge thing too, especially in rural areas.
Oh, yeah.
The transportation and just the getting there part of it.
Yeah. It's really hard. And radiation is a daily treatment, so we have to talk about that and what that might entail for them.
I always, I'm amazed not only at just the talent that you have to do what you do, but also being able to navigate that emotional toll, because you're not a robot, you're a human being. So when you're dealing with these people that are going through this, that's got to be tough on you as well.
I can tell you, when I first started into practice, it always bothered me the most when I had a woman who was young, and especially younger than me. Well, now everybody is. So.
Not everybody.
But it is, because you have empathy.
Sure.
And you see what they're going through, and then, people have lives. People have things they need to do. I understand that. We're all busy. But it's interesting, because when you hear that diagnosis, it's at a time that you do kind of step back and go, okay, I need to take care of me. It's hard.
Yeah, it's go time.
It's hard because most of these women have been taking care of everybody else.
It's a great point.
So they are not used to that. They might have been getting their mammograms, but they weren't doing all the other things. And so we've taken this time to say, okay, not to dump a lot on you, but also to say, we're here to support you, but we're also here to talk about what can you do to keep yourself healthier. And actually, everybody wants to know. They're like, yeah, what can I do to help fight this cancer? What can I do? Well, one of the things is we're starting to do a what we call prehab exercise program, because we know not enough people do regular exercise, but we know something important, and it's been known for a long time, is regular exercise, healthy eating actually decrease cancer recurrence, not just heart disease. And when I say healthy eating, plant-based. And I'm not saying you don't have to be a vegan, you don't have to be a vegetarian, you can have your meat, but just
work that in.
Strong plant-based diet. And you can have wine too.
There you go. We were talking a little bit about wine before the show. We found common ground there. Talk a little bit about, a lot of research goes into cancer treatment and cancer outcomes, and it's not all medical. A lot of it is socioeconomic. I mean, there are disparities in outcomes. How do you navigate through that? Or have you found something in this area that has there been a clear research study done that shows that there are disparities in outcomes depending on social status and economics and things like that nature?
We've actually been looking not so much at outcomes, but at access, screening, and it's very interesting because, we've heard these numbers for a long time.
Right.
Is there, is it access to care? Is it insurance? Why are some people, some minorities having lower outcome rates?
Right.
I saw it. It's a fairly new statistic, and I'm going to say this because I'm going to talk to the Marshall Network here.
Okay.
I am very, very disappointed.
We're breaking news here.
Yeah, I'm very disappointed that our numbers throughout our network are about 62% of the women of the correct age, and that's over 40, and really they're looking at between 40 and 74, are getting their regular mammograms. And that's employees.
Okay.
The nation is 79%.
So we have a ways to go.
We have a ways to go. This is the number that really blew me away. Black women in the United States, 86% get their mammograms. So it's not access to care.
Right.
It's happening, and that's awesome. Now, there is a problem, and that is with outcomes. There are some populations, and it is more common in Black women, that there are more triple negative tumors.
Okay.
And those have worse outcomes.
Right.
And we don't understand the genetics of that, but that probably is something genetic. But here's the thing about triple negative. More people are cured, more people are living longer. It goes back to finding it early.
Right, and getting those screenings done.
Yep.
So lifestyle choices, eating more plant-based foods, getting your screenings done. Is there any other basic advice you might have for someone that might be watching or listening that might be in a high-risk group that so far, praise the Lord, hasn't gotten to the point of being diagnosed with cancer, but might be saying, maybe my time's coming. What can I do now to prevent it?
So high risk is identifying that you are high risk.
Right.
So we use some risk calculation models that can give you a good idea of what your personal risk is. And that's very important because if it's over 20% lifetime risk, you maybe should be getting MRIs, not just mammograms.
Okay.
Because mammograms are great, but they're not great for dense breasts. And if somebody is higher risk, they might need that MRI maybe yearly, maybe every other year.
So that just takes it a step further.
It takes it a step further. It's much more sensitive. It's not for everybody. It's an expensive, kind of a longer test, but it's very accurate.
What has been the most rewarding thing that you've come across in your time doing this? I know obviously you're saving lives, so that goes without saying, but is there anything else that maybe someone might not have thought of as an oncologist and surgeon that you find ultra rewarding for you, just dealing with this? Such a negative topic, right? But at the end of the day, there has to be something that brings you some, not necessarily joy, but at least comfort in knowing that you're saving lives and helping people.
Joy's not a bad word because so one of the things that I do after we diagnose somebody with breast cancer is I sit down with the patient and their family, and sometimes friends, whoever their support group is, and go through the options. And I find that the most rewarding thing that I do.
You're making bonds that last a lifetime.
Well, it's not just that. They come in and they're so dejected. And they're crying and they're upset. And sometimes I give them terrible news. Sometimes I tell them, well, you know what? This is an aggressive tumor. You need chemo first, and then this is what we're going to do. But most of the time, I'm able to give hope, and that's the part of my job I love.
Right. That's something that you can't put a price on.
Yeah.
So tell people how they can get a hold of you if they just have maybe some advice, or if they know someone that's going through this and they want to be part of the Marshall Health Network and they want to look forward to maybe you helping them out or someone on your team.
Sure.
What's the easiest way to get in touch with you?
The Edwards the Edward ECCC Breast Center.
Right.
304-399-6556.
We'll put that on the screen so you don't have to memorize that.
But yeah, we're happy to, we've got a high-risk clinic. We've got 3 surgeons now, and we're happy to follow somebody who may just be high risk, or maybe you have a question and you're just not sure what your risk is.
And maybe we can work on getting that number up to 80% for all women.
That's what 90 would be.
90 would be wonderful. Yeah, let's beat them. All right. Dr.
right.
Mary Legenza, thank you so much for your time today. It was a pleasure talking to you, and we look forward to continued success for you and your team in the future.
Thank you so much.
And thank you for joining us. Again, if you're watching right now, or if you're listening, by the way, on Spotify, make sure to like and subscribe. That helps us out a lot. And we'll have another episode for you in a little bit. But again, we can't thank the doctor enough for coming in and hopefully giving you some advice that can help you on your path, on your journey to wellness. For the doctor, I'm Rick Lord. Thanks for joining us. Until next time, take care.
was the Health Source Podcast, presented by the Marshall Health Network.